Hey everyone, so we're going to continue with blood and we're going to talk about sickle cell anemias now. Now when we're going to talk about sickle cell anemias, these basically are genetic disorders in which there is only alteration of one nucleotide, and that is because due to a point mutation, especially at the beta region or the beta chain of the peptide hemoglobin molecule. So if you remember, the hemoglobin molecule basically consisted of 4 flowers. If we remember, let's just draw the first flower, let's just draw the second flower. Okay, we have the third one here and we have the fourth flower here as well. Now, those of you who are a little confused about the flowers, we've already discussed it in the physiology section of the blood. So if you want to refer, you can go back there and go about it. Now, we had 4 flowers here of the hemoglobin molecules, and if you remember, 2 had these chains which were the alpha chains, and then there were 2 chains here which were the beta chains. Okay, so we had these 2 alpha chains and we had 2 beta chains here. So the mutations here with sickle cell disease generally happens at the beta chain, and it happens at position number 6 because the beta chain is a peptide, and this peptide amino acid would be made up of amino acid chain. Amino acids would be linked one another, just like you build Lego boxes. So you'll have one amino acid, to it the second would be linked, then to it the third would be linked, and so forth. When we come to the position number 6, then there is a single point mutation here. Point mutations we'll discuss in detail here at the end of this lecture, but then there is single point mutation here. Because of this, problem arises. Now most commonly, if we talk about the sickle cell disease, this affects the African American population more, and roughly it affects the African American people more, and in the ratio of 1:500 approximately. 1 in 500 African American people is generally affected, the Africans as well. So, and this disorder is generally a homozygous recessive disorder. Okay, what disorder is this? This is a homozygous recessive disorder. So now the question arises, what do we mean by homozygous recessive disorder? For this, what we'll do is we'll take a look at the Punnett square here. So Punnett square is basically designed for the genetics, and what we'll do is we'll take a look at the maternal chromosomes and the paternal chromosomes. So just imagine that there is a male here and there is a female here. Now both of them would have the chromosomes which would be consisting of the beta positions. Do you remember the chromosomes? Yes, obviously. So here the male would be having 2 beta positions. Let's say it has 2 beta positions, and one is normal beta chain and the other is sickled. Same ways, the female here would be with a normal beta chain and the other would be sickled here. Let's take these to a Punnett square here, and let us take the male here, and what we'll do is we'll take one beta and we'll take the other beta which is sickled. Okay, same ways we'll take the female here and we'll take the beta and we'll take the other beta which is sickled, and we are going to draw it on a Punnett square. So what we see here is the first beta, and the first beta when we are going to take, this child born is completely normal with 2 beta chains, and the next child here would be having one sickled chain, and one sickle chromosome is not sufficient to cause the disease because it's, as I had told you, it's a recessive disorder. It is not a dominant disorder. In a dominant disorder, only one gene diseased would result in the problem. But here, what we'll see is that this child who is born is actually a carrier. That means even the father was the carrier and even the mother was the carrier because they had this beta chain on which the sickling had happened. Okay, they were not affected, but they were carriers, and when they had married, they had, these child which are resulting. Same ways here we find, okay, beta S and beta. So this child also born would be a carrier only. Okay, you see one chain is sickled. Now you see here this beta which comes over here is sickled, and this beta from the mother comes over here which is sickled. Now this child with both the beta chains having sickling would be resulting in the disorder. Now when both the genes, let's see, when both the genes are sickled, don't you think it's the same condition? And you call the same condition as homozygous. And because it's a recessive disorder, that is why we call the sickle cell disease as homozygous recessive disorder. If we talk about these carriers only, these are heterozygous, don't you see? Because they are having one normal beta chain and they are having one affected beta chain. So this condition, this kind of child is having one normal chain and one affected chain, and that is why he or she would be said to be having heterozygous condition. In sickle cell anemia, there is this homozygous recessive disorder, and heterozygous is not the problem. Heterozygous patients are only carriers. In fact, they are not only patients, they are only carriers themselves. So this is how we see that this is a recessive condition and it required both the genes to be diseased because of the problem which had to happen. And so what we are seeing is that only those individuals who have inherited the two mutant or the two defective genes, one each from parent, on the Punnett square you can see, they result in this sickle cell disease. Now a question arises, when does this sickle cell problem start to show? So this sickle cell problem generally shows if, let me just go back and draw the hemoglobin. Now you remember initially when the child was developing, they had this embryonic hemoglobin, and from this embryonic, when the child had converted into a fetus, the hemoglobin had also changed and had converted into fetal hemoglobin, which was HbF. Now, when the child is about to be born and when this transformation happens roughly at around 8 to 9 months in utero, when the child is about to be born, the fetal hemoglobin is converted into adult hemoglobin, which is HbA. Now, the fetal hemoglobin, if you remember, was alpha 2 and gamma 2. So, till here, when the gamma chains were being represented, the child was not having any problem because there was no problem here because of the gamma chains. But slowly and steadily, as the hemoglobin starts getting converted from the fetal hemoglobin into adult hemoglobin, and as we know, HbA is represented by alpha 2 and 2 beta chains. These beta chains here in this person would be sickled because it has been inherited defective from both the parents. So when this problem has been inherited defective from both the parents, this is when the trouble actually starts. When the fetal hemoglobin starts getting converted into adult hemoglobin, the adult hemoglobin of this patient or this person is defective. In fact, when the child is born, there is a massive destruction of these defective RBCs, and the child actually has a massive congenital jaundice. Okay, sometimes the textbooks also called as congenital hemolytic jaundice because there is excessive destruction of these faulty RBCs. In fact, if we talk about the normal lifespan of the RBCs, the normal lifespan of the RBCs is 120 days. But when these children are born, they, because of the sickling problem, what happens, their lifespan of the RBCs reduces tremendously to approximately 10 to 20 days. Okay, that's very, very less, 10 to 20 days, and it results in excessive destruction of the RBCs. And when the child is born, there is massive congenital jaundice in this child as well. Now, let's see what actually happens here. What is the problem here which has happened? So, if we take a detailed look at the amino acids, we'll find the actual problem. So these, what I've drawn is, this is hemoglobin A, and in hemoglobin A, we are trying to trace this beta chain of amino acids. This valine is the first amino acid, histidine is the second, leucine is the third, threonine is the fourth, proline is the fifth, and Glutamate is at position number 6. In fact, glutamate is at position number 7 as well, and lysine is at number 8, which we are not bothered about. We are bothered here at glutamate. Now in normal hemoglobin A, if you take a look, what is happening? What is sitting at the 6th position? It is glutamate. Glutamate is also said to be glutamic acid, right? And glutamic acid, this amino acid, you see NHCO, CH2CH2, COO minus. So the glutamate, what it is doing is, it is inherently carrying which charge? It is carrying a negative charge. Okay, understand this. The hemoglobin A in the normal U, means that the normal person who is unaffected, this hemoglobin A at the beta chain position 6 is occupied by glutamate. But then what happens in HBS, which is the sickle cell patient, there is a point mutation. See, 1, 2, 3, 4, 5, and when we reach here, what we find here is that now glutamate is not occupying this position. Okay, glutamate is not occupying this position. In fact, what we will see is that glutamate is not there. In fact, valine has been replaced by glutamate. Glutamate is gone and valine is welcome. Now valine, when sits here at position number 6, you can see there is almost no charge here, because valine is a neutral amino acid. There is no charge. There is no charge. And when there is no charge, this would result in a conformational change of charge in the beta cell, and this would result in disruption of the beta chain, which we will look further in 5 minutes. Okay, but taking advantage here, I would like you to explain another hemoglobin here, which is hemoglobin C. Okay, when we take a look at hemoglobin C, so what happens here? Okay, this is not concerned with sickle cell disease, but I just wanted to take the opportunity to show you what even changes with hemoglobin C here. So what happens here is, you see, first, second, third, fourth, fifth, sixth position, glutamate is not present. In fact, here what is present is lysine. Lysine is present, and you see lysine is an amine, and amines, amino acids, generally have this NH3, which is having a positive charge. So we have seen 3 hemoglobins here, and all of them are having different charge. If we take a look at the normal adult hemoglobin, this is having a negative charge. The sickled hemoglobin had no charge at all, and the positive charge was seen on hemoglobin C, because there was a point mutation here. And what happened, that at single position the glutamate was removed and lysine is actually occupying this place. Now there is a beautiful acronym which we have created, and you will remember from now on what was in the normal and what is occupying in the sickle cell patient. So the acronym which we have written here is, we can write is glutamate is gone. Glutamate is gone. This is how you will remember the sickle cell disease. Glutamate is gone because glutamate is normally occupied and it is not occupied in the HbS, which is the hemoglobin S, which is the sickled hemoglobin. Glutamate is gone. What is welcome? Valine is, and the spelling of welcome is by V here, welcome, deliberately. So you will remember valine is welcome because valine is coming here, kicking out the glutamate and sitting over here, and valine in HbS is not carrying any charge. And because of this, what happens is, because of this charge, the lifespan of the RBC also changes. The normal lifespan was 120 days, but now this lifespan would be approximately 10 to 20 days only. Now the question arises, what changes here at the beta position? For this, what we'll do is, we will take this normal hemoglobin, okay? Normal hemoglobin, you see, alpha generally, if you draw it here, has a pocket. Beta doesn't have any pocket, okay? Then another beta is sitting here and another alpha with a pocket is sitting here. So this is the normal structure of hemoglobin. Hemoglobin is a tetrad molecule, as I had told you. The normal configuration is stated by alpha 2 and beta 2. 2 alpha you see are sitting here and 2 beta are sitting here, uniting to form the normal hemoglobin molecule. But in sickle, see what happens. In sickle cell, in sickled hemoglobin, what is happening here? We're going to have this pocket here on the alpha, but on the beta, because there is this change of the charge, now it is neutral, this develops a spiked area. This spiked area, this pointed area now sits in the alpha pocket, okay, like this, right? In fact, another spike would develop at the beta portion here, and this is the alpha, okay? This is the sickled hemoglobin. You see, this is the alpha portion with the pocket. Now the beta, you see, is inserting its spike here and fitting well into the alpha pocket. In fact, this is where a chain of hemoglobin starts to form. You see, another hemoglobin would come here. When another hemoglobin comes here, this is the pocket and this is the spike. They start fitting into one another. And when they start fitting into one another, you see, this is the alpha, this is the beta pointed spike, this is the beta pointed spike, and this is the alpha. When the beta pointed spike, they start fitting into each other, a chain starts to happen, and this hemoglobin, which is the HbS, starts to collect together, starts to stick together, start forming very, very longish chains, and it starts to getting lodged here in very, very thin vessels also, because certain blood vessels are so thin that the RBC has to pass as a single file. But here what happens, they have formed a complete chain here, a clumping here, so they start getting accumulated in those areas which have very thin, fine blood vessels. And these problems in these sickle cell patients are called as crises. And these crises are very, very painful. You know what happens? Especially imagine, for example, there is the area of the head and there is a minute blood vessel, let's say in the brain. And this minute blood vessel, let's say, start getting clogged here because of these sickled cells. Now, do you think this region would be receiving any blood? Obviously not. And this patient might be suffering from an intense headache. In fact, headaches in sickle cell patients are very, very common, and these are crises. They are having constant headaches. In fact, what happens is, wherever there is thin supply of blood, those are the areas where problems start to happen. In fact, what happens is that the RBCs start getting destroyed also massively in the spleen, because the lifespan had reduced. Because of all this sickling, the lifespan had reduced of the RBC to approximately 10 to 20 days. And because of this, what happens? The spleen, you remember, was the graveyard of the RBCs, and these were the cords of Billroth. So in the cords of Billroth, these clumping and dead RBCs started getting stuck. And because of this excessive destruction, the spleen increased in size, and there was massive splenomegaly as well. There was massive splenomegaly here in these patients because of the excessive destruction of the RBCs. There are some bony changes as well, because now what happens is, in fact, even your bone marrow, okay, remember the bone marrow, it is under constant stress to produce RBCs, and because the RBCs, they are being destroyed so quickly, the bone marrow is under a constant stress to produce RBCs. In fact, this also results in hyperplasia of the bone marrow, which is called as bone marrow hyperplasia. Okay, so what we are seeing here is that there is bone marrow hyperplasia in this patient, there is splenomegaly in this patient. What else? What other trouble can happen here? In fact, in this patient can suffer from stroke as well, because who knows, these RBCs start getting stuck in the brain, and there they start bleeding and results in a stroke in a patient. And renal dysfunction also starts to happen, because these RBCs would go to the renal area, start getting lodged there, and the kidney also would not function properly. In fact, what happens is, in some people, lung infections also tend to happen, and that is called as acute chest syndrome. That is called as acute chest syndrome. So you see what happens in these sickle cell patients, because we had replaced only one amino acid and there was only 1 point mutation, and glutamate was gone, valine was welcome. Valine had a neutral charge, glutamate was having a negative charge, and because of all this, the problem starts to develop and the whole body generally you see is affected, and this is called as crises. Okay, what is this called? This is called as crises. So this is a huge problem in these sickle cell patients. Again, what happens is, because of what happens, these pointed things are happening. They have in fact changed this is the normal biconcave disc shaped RBCs. Because of this, the shape of the RBC is also changed and it looks like a sickle only, right? So the shape of the RBC is also changed because there is a conformational charge change here, and glutamate was negative. Now it has been replaced by a neutral molecule. Why has this problem actually developed? So God, you call it God, you call it nature, or you call it the Darwin's evolution. What happened was that there were plenty of mosquitoes in Africa. Okay, when there were plenty of mosquitoes in Africa, so these African Americans, where is the problem seen here? The problem of sickle cell is seen in African Americans and Africans. So in Africa, there were plenty of mosquitoes, and these mosquitoes used to bite these Africans, and they started dying because of the plasmodium, which was the malaria. And now you know that malaria actually completes its life cycle inside the RBC. It needs to float around in the RBC because the RBC becomes the host and the plasmodium becomes the parasite. And that is where the parasite grows and it starts to cause malaria. But then what happens, these people start developing mutations, and there was one beta and the other beta started to mutate and started becoming sickled. In these people who have mutations, some of their RBCs have a lesser half-life. Okay, obviously some of these RBCs will have a lesser half-life, and it is going to protect them from the Plasmodium falciparum, because it used to complete its lifespan in the RBCs. So nature took over and it caused a mutation in the beta position, and this is where the beta, some of the RBCs at the beta position were starting to have lesser half-lives. And because of that, what happened, that these people started getting immune to malaria, especially the one which was killing them, which was Plasmodium falciparum. So God actually, or nature, whatever you want to call it, caused this mutation to protect them from malaria. But then what happened, you saw that this was happening generally as a heterozygous condition. But when two heterozygotes married, it could result in a homozygous condition in which both the beta genes became sickled, and this is where the problem arose of sickle cell anemia. Okay, so next what we are doing is, you must be wondering, why have I drawn this big diagram and still not talked about it? Okay, so this is a process which we generally do in just to detect. It's a lab test which we do to detect sickle cell disease, and this lab test is called as electrophoresis. So in electrophoresis, what we generally do is we produce a charge over here. Okay, what we do is we produce a charge here. We create a positive electrode here and we create a negative charge here. Okay, and we generally put 3 drops of blood here. The 3 drops of blood here, you see, this lower one, the middle one, which is the blacker one, is the hemoglobin S. And if you take a look at the hemoglobin S, would it move towards the positive or would it move towards the negative? It would not move anywhere. Do you know why? Because the HbS, the sickled hemoglobin, was having no charge. Do you remember? It was having no charge. Now, if you take a look, the hemoglobin A had a negative charge, and if you take a look, the hemoglobin C had a positive charge. Whenever we apply this now electrophoresis, the negative hemoglobin would run towards the positive, right? Isn't it? Which is the negative hemoglobin? It is your normal adult hemoglobin carrying the negative charge. It would rush here towards the positive side, isn't it? Just the opposite thing is going to happen with HbC, because the HbC was carrying the positive charge. It would move towards the opposite end. So this is a test which we do in laboratory, and this is called as hemoglobin electrophoresis. We apply electrodes which are positive and negative, and we see that hemoglobin S, which is the sickled hemoglobin, is not going to move anywhere because it is neutral. But then we see that the hemoglobin A, which is your normal adult hemoglobin, moves towards the positive end because it is negative. Why negative? Because the sixth position was occupied by glutamate, and glutamate was having a negative charge. Opposite is going to happen with hemoglobin C, because at the sixth position this was occupying a positive charge because of the amine molecule. So this is how you do this process, electrophoresis, and you immediately know what kind of a hemoglobin it is, isn't it? So isn't it a wonderful test which we are doing here, which is called as electrophoresis. Now next what we'll do is we are going to talk about the laboratory and the radiologic features. As I had told you, when there would be massive destruction of the RBCs, when the child would be born, there would be congenital hemolytic jaundice. Okay, there would be congenital hemolytic jaundice. In fact, here in these patients, we would also find these immature RBCs, which are reticulocytes in the circulation. And because of this, the reticulocyte count is massively elevated. Okay, the reticulocyte count is massively elevated in these patients who are suffering from sickle cell disease, and because of the excessive destruction of the RBCs, the lactate dehydrogenase levels are increased, and because of the same process, the haptoglobulin levels are decreasing because there is a massive destruction of the RBCs. Okay, always remember, congenital hemolytic jaundice, increased reticulocytes, increased LDH, and reduced haptoglobulin levels are a feature here, laboratory feature of the sickle cell disease. Now, these haptoglobulin levels and all we'll talk about more in detail in general medicine, but you just understand and write these concepts. Okay, if we talk about the radiologic feature, again you see here, can you see the hair on end appearance? Yes, because here also what we find is that the marrow is under extreme stress, and when the marrow is under extreme stress, there is hyperplasia, and between the cortices you can see these areas which are developing here. So you see the hair on end appearance here as well in sickle cell disease, hair on end appearance, but then this is not that massive as massively it was seen in thalassemias. And I had told you, whenever they ask you a question, where do you find the hair on end appearance? So if both the options are given, sickle cell anemia and thalassemia, go for thalassemia. But if sickle cell anemia is given and three other options are different, then you can go with this appearance, because here also hair on end appearance is appreciated. So this is all about sickle cell anemia. Next, what we are going to do is we are going to talk about a condition which is called as erythroblastosis fetalis. What we are doing in oral pathology is we are covering all the disorders which are RBC disorders. Okay, so the next disorder with the RBC disorder is called as erythroblastosis fetalis. So what actually happens here? This problem is seen when an Rh negative female marries an Rh positive male. Okay, and when they cross, let's see what happens. When the first child here is in the uterus, let's say the first child is Rh positive. And let's say the first child is Rh positive. Rh positive, what is Rh positive? I'll show you. So for that, let me just draw one red blood cell, and these carry an antigen. And this antigen is said to be Rh. Why Rh? Because it was found on rhesus monkey first. Okay, and that's why this antigen is called as Rh antigen. Now the point is, this is being carried here by the fetus. Okay, this is being carried here by the fetus. So all the cells. Now you see, the mother of this fetus is Rh negative. When the mother is Rh negative, the mother's, what happens? The antibodies realize that something antigen has come from the foreign source. And now what happens? The mother starts producing antibodies against these antigens. Okay, so you see here, the mother actually starts producing antibodies which are called as anti-Rh antibodies. Now this is not going to harm the first child. Why? Because these antibodies initially are formed and the female now is sensitized. You can see these Rh antibodies now developed in this female, and they are now all are filled up and ready to attack a second child. Now for example, there is second pregnancy here, and in the second pregnancy, when the second child is coming over here, what we see is, if the second child is also Rh positive, now let's say the second child is also Rh positive, now the female has developed enough antibodies to attack the child's RBCs. And this is where an antigen-antibody reaction is going to happen, and the RBCs of the child are going to be massively destroyed. When the RBCs of the child are going to be destroyed, now this child can suffer from jaundice, and there can be other complications as well. If we are going to talk about the complications here, this destroyed blood pigment, which is bilirubin and biliverdin, you see here, starts getting deposited in the teeth as well. Can we see here? And you can see this greenish yellowish pigment which is being deposited here. Now this greenish yellowish pigment generally is deposited in those teeth which are developing first, and this happens in the cuspids and the first molar. Where do you see this more? Cuspids and the first molar. In fact, what happens is, let me draw a molar here. If we draw this molar, what we find here is that there is a destruction band. There is a band here which is discoloration, and discoloration is basically signifying that the RBCs were destroyed when this tooth was developing. So this encircles the tooth in a three-dimensional pattern. Okay, this discoloration encircles the tooth in a three-dimensional pattern, and this is called as RH hump. Okay, so RH hump is very characteristic of, it's a ring-like defect which is seen around the first molar here. Okay, so sometimes it can also be seen over the incisal edges when the incisors were developing at that point of time when the fetus was developing, and where this reaction, this destructive reaction was happening. Now to prevent this, anti-D injections are given. They are very expensive injections. So to neutralize these antibodies in a mother, anti-D injections are given nowadays, and nowadays you encounter the problem of erythroblastosis fetalis very less. Okay, moving ahead now, next what we are going to do is, we are going to talk about Plummer-Vinson syndrome. Now Plummer-Vinson syndrome is a problem generally characterized in females and is seen basically because of iron deficiency anemia. In fact, there is another name of Plummer-Vinson syndrome, other book. Do you remember? Okay, so you write it down. The other name here is Patterson-Brown-Kelly syndrome. Okay, it is also called as Patterson-Brown-Kelly syndrome. Okay, Plummer-Vinson syndrome is also called as this, which is Patterson-Brown-Kelly syndrome. And here what happens, these patients generally have iron deficiency, and especially seen in females, and it was researched in Scandinavian countries. Scandinavian countries are Sweden, Finland, Denmark, those countries, okay? Right, so why is it very, very important here? Because in Plummer-Vinson syndrome, you have anemia, and because of the anemia, you will have this inflammation of the tongue, which is angular stomatitis. It can be a beefy tongue as well, but then beefy terminology was generally, if you are not confused, beefy terminology was used with two conditions. You had beefy tongue with B12 deficiency, and you had raw beefy tongue with niacin deficiency. Same ways you can have stomatitis here, because the iron deficiency also results in depapillation. Now, what happens here, that a web here in the esophagus generally forms. When a web here forms, now in the esophagus, when there is a web, do you think you would be able to swallow easily? Obviously not. You would have difficulty in swallowing, and this results in dysphagia. Okay, dysphagia is the difficulty in swallowing because of the esophageal web, and this esophageal web has a predisposition to cancer. Okay, this can later on convert into a cancer. Okay, a carcinoma of the alimentary tract, especially the upper alimentary tract, is seen in these patients who are suffering from Plummer-Vinson syndrome. Now, this is generally seen in females, okay, who are in 4th to 5th decade of their life. This is where iron deficiency is most in these females, and you would find low serum iron, low ferritin. Okay, what would you find? Low serum iron. You would find low ferritin, and there would be increased total iron binding capacity. Okay, that also happens. Now, if you would want to understand more details here, we have certain micro lectures of microcytic anemia, macrocytic anemia, normocytic anemia in your oral pathology folder in the app. So you can obviously refer, if you want to extract extra information out of the blood part, you can take a look at those micro lectures. Now, those micro lectures would be in detail covered in live in the general pathology when we are doing it. Right now you cover that and you cover this much, and I think you are safe with no other thing need to be done. Okay, so just reminding you that there in your app you have the oral pathology folder, and in that with the live lectures you can watch those micro lectures of microcytic, macrocytic and normocytic anemias to add this extra information. What is TIBC, what is iron, ferritin, so this, what are the other acronyms, that extra bit of information you can find in those lectures, so you can cover it from there as well. Okay, so coming back here, what I was telling you was that this syndrome with iron deficiency is called as Plummer-Vinson syndrome, and it is also called as Patterson-Brown-Kelly syndrome. Okay, moving ahead. Next, what we are doing is we're going to talk about polycythemias. When we're going to talk about polycythemia, poly means multiple, that is increased. Emia is the increase of RBCs. So in polycythemias, we have massive increase of the RBCs, and these can be of two types. The polycythemias can be primary polycythemia, and they can be secondary polycythemia as well. The primary polycythemia is also called as erythemia. Okay, this is called as erythemia, and the secondary polycythemia is called as erythrocytosis. Okay, right? Erythemia is the more dangerous problem because the whole marrow is pushing, and because of maybe some unknown condition also extra RBCs are being formed. Erythrocytosis is a transient condition. Maybe it is seen in anemic patients, or maybe bone marrow is under some stress, so it is resulting in excessive production of the RBCs. Okay, now the secondary condition is a transient condition, we know the cause. The primary condition, you have another name here, and this is called as polycythemia rubra vera. Okay, what is the primary polycythemia called? It is called as polycythemia rubra vera, and we have other names here of primary polycythemia as well. This is called as Vaquez disease, and it is also called as Vaquez disease, and it is also called as Osler's disease. Okay, so we have these other names of primary polycythemia which you should know. Now, what happens in primary polycythemia? In primary polycythemia, do you remember the bone marrow house? Okay, so this is the bone marrow, and it is massively forming excessive RBCs. But then it doesn't stop here. The bone marrow with the RBCs start to form increased WBCs as well, and it starts to form increased platelets as well. So that means there is increased production of RBCs here in primary polycythemia, increased WBCs, and this also results in the excessive formation of platelets as well. Platelets are also formed here. Now what happens? You see, everything is elevated. And because of this, what happens? The spleen is under a constant load. Do you remember the spleen? The spleen had these cords of Billroth. And the cords of Billroth, when you will have this massive flow of RBCs, it would say, oh my God, so much amount is coming. What will I do? Imagine spleen as a big fat man now. He's getting extra food to eat. Nom, 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 nom. The spleen is eating so much. Don't you think the spleen will get fat? That happens because of the massive destruction and the eating up of the RBCs. There is massive splenomegaly also, which is seen in these patients. Okay, there is massive splenomegaly here. In fact, the WBC count is also elevated, and in these patients the RBC count is also extra elevated. Now the last thing which I wanted to talk about here were the mutations, and these mutations are a little bit extra knowledge which I want you to give. I actually wanted to cover it with general pathology, but it's okay, I'm covering now. And these mutations are basically pertaining to the understanding of the sickle cell anemia, and these are pertaining to the understanding of thalassemia. Now let's take a look at the mutations. How do they happen? The mutations can be single nucleotide based substitution. Do you remember your sickle cell anemia? In sickle cell anemia, the single nucleotide, how was it being replaced? Glutamate was replaced by valine, isn't it? Okay, so that single mutation which was happening here was called as a point mutation. Okay, what was this called? It was called as a point mutation, and point mutations can be of three types, which we'll take a look at it in a couple of minutes. But let's first focus our attention to another mutation. You see, two mutations were happening. Either it was a single nucleotide substitution, or either the mutation can be as a frame shift mutation. So in frame shift mutation, what happens is there is either insertion of the extra strand or there is deletion of the reading frame. If you remember, the reading frame generally consists of triplets like AUG, AGA or something like that. These consisted of triplets, and these triplets, when they were read here, they were resulting in the formation of amino acid. Let's say this was first amino acid, second amino acid, and third amino acid. Now to make this simpler, what I'll do is I'll write something which is a triplet. Okay, I'll write Tom, Red, Cap. Yes, so these are triplets as well. TOM, Tom is a triplet, RED is a triplet, and Cap is a triplet, and it is making sense. Now you imagine what I'll do is, let's say I add an extra A here in front of the Tom. It has to be converted into a triplet. It would be converted into ATO, isn't it? A has been added here, ATO. M would shift here. Now this would be read as MRE. D would shift here. It would be read as DCA. And now P is left behind. Do you think this is all making any sense? Because what has happened, the whole reading frame has shifted because of an addition of a single nucleotide. When a single nucleotide is added, this whole reading frame changes, and now you see it is not making any sense. and this is called as an addition frame shift mutation. Same ways, we can have a deletion frame shift mutation as well. In a deletion frame shift mutation, let's see that the T is deleted. Now let's see, when the T is deleted, what is going to form? When the T is deleted, you see, you have OM, and now R would come forward. You have OMR, okay? R has gone forward. Now you have ED, and the C would come forward. You have EDC, okay, right? And you have, what is left here? AP. Ultimately, AP is left, and you see nothing is making sense, right? Ideal statement to be read here was Tom red cap. But because T was deleted, OM were left out, and OM, the third triplet here attracted, was R. Now it is read as OMR, not making any sense. So these are not making sense, and these are huge mutations. Frame shift mutations are huge mutations. They can also result in cancers in the body, because it is not, this whole DNA now is not being read out properly the way it should be read out, because of either an addition or either a deletion of a reading frame. Big problem. Compared to this, the single nucleotide base substitution, now you see, is a lesser of a problem. And as discussed, this could be in the form of a point mutation. Now the point mutations of the single reading frame, when they changed, could be of three types. They could either be silent mutation, they could be missense mutation, or these could be nonsense mutation. In silent mutations, you see what happens is the same amino acid is going to be formed even after the codon has changed. For example, let's see what happens. Let's say a triplet here is A. And now let's see, there is a change here, and this A is gone. And let's say you have A, and now the A is gone and it is replaced by G. You see, the AAA, let's assume, was making an amino acid which was lysine, isn't it? Okay, it's true actually. Now when there is a silent mutation, what happens? The A here has been replaced by G. It has become AAG, but still it codes for lysine. So you see, the internal structure of the reading frame has changed. But then what happens is the amino acid still is being formed, which is the same, and this mutation is called as the silent mutation. Yes, okay. Next, you see what happens in missense mutation. In missense mutation, this is the classical example of sickle cell anemia. This is the classical example of sickle cell anemia. And here what's happening in sickle cell anemia is there is replacement of one amino acid by another. Do you remember at the 6th position what was there? It was glutamate. But in sickle cell disease, this has been replaced by valine, and only one thing changed. And this mutation, because of only one replacement of amino acid by the other, is called as missense mutation. And the classical example of missense mutation is what? It is sickle cell anemia. Wonderful. So if you understand that, yes, it's a eureka moment. Okay, moving ahead. Next, what we are doing is we are talking about the nonsense mutation. Now in nonsense mutation, what happens is the replacement of an amino acid is actually replaced by a stop codon. Do you remember the stop codons? If you remember, in biochemistry, the starting codon was AUG, that was the initiator codon. The stop codons are UAA, UAG and UGA. Okay, what changes here? Let's say in nonsense mutation, we had an amino acid which was UAT. Just assuming, okay, we had this triplet to be read here as UAT, and UAT was coding for something, right? But then let's say there is a mutation here, T is gone, and UA, now the T is replaced by G, for example. So what happens? Now it becomes a stop codon and nothing is formed. The amino acid stops to form, no peptide chain is formed, and no protein ultimately is going to be formed here, because what happens, a region which was coding for something now actually is being replaced by a stop codon, and this mutation is called as nonsense mutation. So in nonsense mutation, what is happening, there is the replacement of the amino acid by a stop codon, and when a stop codon is there, nothing forms. Do you know where this is seen? This is classically seen in thalassemia. Do you remember? If a stop codon of a beta chain was there, then there was beta thalassemia minor. If a stop codon was there on both the place, this would be beta thalassemia major. And same thing could be happening in alpha thalassemia when the chains could be replaced by stop codons. Nothing is formed. Do you remember in thalassemias, in beta thalassemia, no beta chain was formed, and in alpha thalassemia, no alpha chain was formed. And this is about the point mutations, which could be silent mutations. That means the internal structure has changed, but the amino acids are formed. In missense mutation, you had one change and the amino acid changed, resulting in a disease. The classical example of missense is sickle cell anemia. In nonsense mutation, what was happening? The codon was replaced by a stop codon and nothing was formed. And the classical example here is that of thalassemia. So this actually wraps up the RBCs. Next lecture which I am going to talk about, the live one, would be the WBCs and the platelets. I'll take them both along and we would try to wrap blood. I'll see you soon.